So welcome, Michael. It's so great to have you with me on Trainer Talk, and we're talking about EFT and addiction. So glad to have you here.
Well, thank you. It's delightful to be back with you again, Becca.
Let me just introduce you briefly, and then I think our conversation will certainly say a lot about who you are and what you're about in our EFT world. And you are a trainer, founder, director of the Atlanta Center for EFT. You're a partner, owner in Pine River Psychotherapy, and of course you have your own practice, Michael Barnett at LPC, that people can find you. And you have been really involved in working with addiction, I think across your career, but more specifically, you were recently involved in a longevity study about addictions. And maybe, that would be great if you could tell us a little bit about that, because it's so cool.
Sure. And I'll speak to this in a contextual way. So starting with having taken my own externship back in the day, and there, at least in my interpretation of the way things were taught, there was a rigidity around contraindications. And in Atlanta, by the time I was cutting my teeth as a psychotherapist post-graduate school, you couldn't get your supervision hours anymore at community mental health centers. They were gone. So we had addiction centers, most of us trained in, and I was very versed at that, 6 or 7 years of inpatient. So I was having success in my practice with people who were somewhere on the addictive continuum and began getting very curious about this. And in the meantime, many people who were working at treatment centers were getting trained in EFT. So there were 3 people in particular, one of whom was a clinical director at a very relational program. And I'd just been scratching my head for a long time thinking we should do some research, even though I'm not a researcher, I'm such a clinician. But I said, I have a feeling if we try to integrate this into their treatment protocol and we stabilize people's relationships through creating secure bonds, we're also going to stabilize recovery, because relationship issues are one of the biggest triggers for relapse. Yeah, triggers, exactly. And so I had these 3 very well-trained people, and I didn't know how to create a research proposal, and someone taking core skills was all but dissertation and came up to me and said, do you have like an idea? I said, as a matter of fact, I've set this whole thing up. I don't know how to do the research. And so we put together a 3-year project, and every week these 3 therapists would come in with their tapes of sessions from this particular center where the only difference in what these people were receiving was EFT. And it was a powerful experience for me. I learned a ton clinically. The preliminary results that were a function of this the dissertation needing to be turned in after 15 weeks of the study was that every single person who was on a measure, specifically in the anxious attachment frame, moved in a statistically significant way towards secure attachment. And that was both using partners and non-using partners. But we haven't seen the whole outcome analysis yet. But it was very exciting. And like I said, I learned a ton just from sitting there week to week.
Well, and the clinical work of being involved there in an inpatient setting, doing what really we were taught originally not to do, right? Like, work with couples, work in an active addictive process. And, that's probably something important for us to mention, because there is still maybe some mythology around that rigidity of contraindications.
Yes.
And we probably ought to talk about that a little bit, because that's one of the questions that comes up as I'm training around the world is, this person is doing this, or they're addicted to that, or can I even see this couple because of that kind of process? And so I know you have a response for that. I do too in my trainings now, but we could talk a little bit about that evolution and break a bit of that mythology, even though I know it's a bit complex.
I think that's wonderful, and some of it I think extends beyond the scope of simply EFT, but just psychotherapy, because now we're talking about gray area, and there isn't a clean-cut set of decisions here, right? This couldn't be a multiple-choice answer.
Right.
So, what I love about how we talk about contraindications in EFT is actually all about safety. And can we create
That's right.
predictable, reliable safety psychotherapeutically? And so to zoom in a little closer, since our model is predicated on helping people move into more core vulnerable emotion and then risking with their partner, if a partner is prone to relapse consistently, prone to somehow being in the throes of their addictive process and therefore not being available for their partner, that could cause that partner a lot of pain. And so we would elect not to move forward with using EFT in that regard. There was a very powerful piece of research that was done through the National Institute of, I think, Mental Health that said 85% of people struggling with addiction actually find their way through it to some degree without formalized treatment. And the reason I'm mentioning that here is that I believe there's a very clear and wide swath of a continuum from people who use to people who abuse to people who are dependent and then people who are, I would say, clinically and biochemically addicted. And the first three segments, we can actually use some modified approach to our model, which is a breath of fresh air. It's such a relief.
If we know how to assess that. So let's just repeat that, because one, we know we're in the gray zone already.
Yes.
Whenever we're talking about EFT and addiction, we're walking in the gray.
Yes. Yes.
But there's more light around a couple of things. And one is where on the continuum of usage and or addiction they are, right?
Yep.
And the safety factor. So that's really important. And I think also that the expectation around, I mean, we'll do some modifications, like you said, even if they're people we can work with because they are in abuse, you know, they're not in the chemical brain change actively addicted, where there is such a neurological change and that addict button is on full force. Like that's where we kind of say we can't modify to work with you in this kind of systemic process that we're involved in.
Right. That's right. I mean, some people actually aren't even amenable to psychotherapy at that point.
No, that's right.
Most of us don't see them in our private practices, but you see them in treatment centers. But yeah, we can't really do this.
Right. We can't even do some sort of modified version around it. There's a lot of the abuse, you know, addiction in the way of that wouldn't qualify for full scale, but that is abusive and on that going that direction, could be going that direction, that we can do a lot of stage 1 work, and it's really very helpful to do. And I think it's helpful whenever we can meet those. And there, I guess the other part of assessment is not only client assessment, but our own experience, skill, understanding, assessment as well, like where we are in our comfortability with looking at the different, and what our trainings perhaps have been, if we've had any, in the way of addiction treatment.
I would agree. I think if we want to start at like rock bottom, I always like to ask in the master classes, how many people ask about addiction just straight up in an assessment? And very few people put their hands up. And it could be something that's running behind the scenes and actually will really impinge on the therapy process. But I love what you're saying here, in that knowing something about addiction is really important and very helpful. And we have our own, everybody has their own experience around addiction, whether it's something they've gone through personally or a family member, a friend, clients, colleagues, and even our whole culture has a certain way of looking at addiction. And it can really cloud our lenses in terms of what we see in front of us, and then how we work with it, of course, you know, is based on that.
So during that assessment process, one thing is to think about, are we asking, right? About addictions and what kind, and because we know there's both chemical and process addictions, which to ask about both of those flavors, you know, can be, and I think it has to do some with where our culture, where our kind of what shows up in our practices. right? The age group that we're with. So it's a good thing to evaluate some of that, and some of that you'll hear from your clients, because clients, certainly partners, will, if we don't ask, sometimes that it gets brought up, but right. We can get a flavor maybe of the kinds of questions, and kind of start broad and narrow in, right? When we're asking around assessment questions.
Yeah, so it seems to come about two ways. Either people haven't mentioned anything, so I would simply ask very bluntly, is there anything about substances or certain behaviors that are ongoing in your lives that we need to address in this process? Because people have a lot of shame about this stuff, and oftentimes
it's hard to bring up.
Yeah, couples get very complicit in not bringing it up. Even if there is one partner that's a using partner, the non-using partner often will not go near that.
It reminds me of a couple I had that came in, and it was a failed treatment. They split up, they quit therapy, they split up, and then a couple of weeks later, it was a married heterosexual couple. The husband came in just to debrief. I didn't continue treatment with him, but he came in, actually just said, I want to come in and apologize because me and my wife, she convinced me not to let you know, right?
Wow.
And so I was holding the secret the whole time, and that, I think, is what ended up blowing us up. Right? And at the time, I wasn't, I didn't ask either, I don't think I didn't ask either. It was very early in my EFT career. And I was doing outpatient treatment in addiction group work. But still, the couple work was new, and I didn't ask, and they didn't tell.
Yeah, so that is a simple addition to anybody's kind of assessment protocol. I just would encourage, just ask. The other way it comes in is people do acknowledge it, and then we want to start exploring more detail about it, and I think even get more into the granular detail in the individual assessments, how that's impacting the relationship, what it really looks like, if both partners' stories are congruent or not, which often they're not, to get more detail about the breadth of the addiction and the impact of it.
Right. And then we have to, and I think the training is really helpful to start to develop some comfortability as we move into couple therapy, attachment, and interventions. But we do need to kind of initially assess our own comfort level, right? And our own biases. You mentioned, like, we all will have known someone either very close to us or in our circle somewhere, or certainly it's in the media. We're going to have some biases and some feelings around approaching or avoiding the topic, right? And that's important, I think, for us to be aware of as we start to work with couples who have these issues.
So see our own lenses. I tell a story about that in my training. I had a really great friend that I knew through, like, my bestie growing up. And he lived in Colorado, became friends with my circle of people when I was in undergrad and then grad school. And this couple moved away. And unfortunately for this guy, he developed a horrendous heroin addiction. And my friend, his partner, called and said, we got to get him help. Can we get help? We arranged it. She went to pick him up and came home, and he was dead with a needle in his arm. Fast forward many, many years, I was doing therapy with a somewhat non-complicated client. However, he was this kid that had everything going for him. When I say kid, 25, supportive family, smart, well-educated, and he kept relapsing. And very uncharacteristic of me, I found myself angry at him all the time. That's so not me. And so I went into my supervisor and I started saying, this is not making sense to me. I know how to work with addiction, and I'm, like, frustrated with this guy all the time. And he just got quiet. This supervisor was a mentor for 27 years. He really knew me well. And he said, does this remind you of anything? And I just started weeping. And I said, I've been angry, I'll get choked up here, at my friend, but I could never embrace the grief. And so our experiences can blindside us clinically very easily. And addiction is close to home. It's everywhere. So we've all had.
It's so painful. It creates so much pain and so much disconnection, right?
Yeah,
so our attachment systems are so impacted by it, especially the very close experiences that we've had with it. So thank you for sharing that.
You're welcome. I'm surprised I got choked up there. That I've told that story a lot and don't usually get too emotional about that. But you're welcome.
It's good to be aware of it, right? It's even looking back to go, oh, what, I mean, even that you went to a supervisor using this example, right? Even that you recognize I'm not being able to work the way I usually work, or something about this is stuck with me. Even that curiosity that you took and that you took to a supervisor, I think is such a good model, Michael, right? Like, that's a message that we want to make sure that therapists are aware of, that we, especially when we're working with emotion and attachment, because we are the tool. Our attunement, our ability to be present is so much of the tool of the therapy, that when we're feeling cloudy, blocked, inefficient, that getting support is really essential.
It is. And I would even add another layer, especially when we're working with addiction, because there is the presence of so much trauma and shame and the secondary traumatization that can happen to us, and then our own personal experiences. It can get very murky very fast. So
yeah, there's so many intricacies that are happening.
Yeah, it's very complex
through the process.
work.
Very, very complex work. So we've kind of talked about the assessment, some of the contraindications, and there's another thing, I guess, that we were talking about in our preparation to kind of chat together.
Yeah.
When we're talking about addiction and the models that maybe we've come in with. Like, lots of us are familiar with 12-step models, or we've run into that if we're working with people who are in recovery and been in recovery. Maybe it's not active, they're in active recovery and not so much needing to stop the behavior. They're preventing relapse in an active recovery. And that's a place that sometimes we get stuck with our couples when it comes to the 12-step coming up, because it's so widely used and is kind of a first course for people who wouldn't seek psychotherapy to get help, right?
Right.
So I don't know if you have anything. I don't think it's a big topic, maybe for us to chunk down onto.
I'll just make a couple comments, because I think there's some sensitivity that's worthy of being attuned to, and that is the 12-step model, in my opinion, ironically, is not a attachment model as we see it. It is attachment in terms of the fellowship. And when people are interviewed about what's helped them in the program, more often than not, much more often than not, people talk about the fellowship, not the steps, which is very interesting. But we use attachment and our interventions to deliberately leverage attachment and activate the attachment system as a way of moving very much into people's characterological structure. Right. And we are helping partners antidote each other's historical pain and issues. So the only reason I say that is I have had countless experiences when people come into therapy having been in the program, and they'll say things like, well, I'm just going to work my program and she's going to work hers.
Right.
And it is so foreign. It is so foreign to think
and
that they're married.
I'm going to call my sponsor, and I don't tell you that I even had an incident that I needed to call my sponsor.
That's right. And so the partner gets shut out, and then it destabilizes the relationship. And then all of a sudden there's a trigger for addiction. So I kind of see us as emissaries for both and. This is another set of resources that people being able to lean into their relationships can stabilize the heck out of recovery. And people having a good sponsor and a fellowship and a home group they go to, that's all really good stuff.
It's really good. And I also have my bias is that group work, I was born doing group work with addictions. So that was my first introduction to working with addictions, was in groups.
Yes.
And it's so powerful to have that additional support and normalization and some of the psychoeducation that happens. And the couple therapy it's necessary, but I don't think sufficient for many people, right?
I
So
completely agree
having
with you.
that additional, I can go 2 or 3 times a week or every day, or at least it's not, everything is not hinging right on the couple therapy.
Exactly.
And it could
I
titrate out of it when, as the couple gets stronger. But I really come to rely on those group referrals. If people can find a good group to participate in, it is a little tricky as far as the norms about who you call and what you share and what you don't share, and that kind of thing. You know, different groups get different flavors. But I found it really helpful to have that additional group work. Even more helpful than some of the individual work, actually.
I'm right there with
more
you.
people.
I'm right there with you. That, you know, we were mentioning shame briefly, but when people sit in a group and they hear others telling their story and they feel not alone with it anymore, and it normalizes things, that process of universality, it's very powerful. And they're learning how other people are coping. And I think it's essential. I'm so glad you said that. I think it's really essential.
Yeah, I thank you. Good.
Yeah.
Hey, we didn't even know we shared that.
No, but I'm finding it especially useful. You know, I think the same thing. And I have noticed that over the years as well, that it seems to be a more powerful resource than simply individual work.
Yeah. So there's a question in the chat box, Michael, about, you know, you mentioned use, abuse, dependency, and then the addiction, the chemically addicted, and the chemical addiction being the real contraindication. Yeah. But they want us to kind of differentiate between dependent and chemically addicted.
Yeah. There becomes a juncture in people's neurobiology where, so this opens up a really big topic in my opinion. This is one that I struggle with, by the way, or I become a bit of a heretic, but that's okay. Because it starts to tap into the notion of addiction as a disease and the disease model.
Right.
And
right.
I've had some pretty heated discussions with people. I tend not to believe that. And what I have heard, and the most compelling argument that begins to more safely use that language, was there is a diseasing of people's neural networks, and that is real.
Yes.
And when addiction and use and abuse when it's gone past all of that, even past dependency. So someone once said to me, you know, use is kind of like I'm curious about it. Abuse is I want it. Dependency is I need it. And then when we move into addiction, people's neurobiology is genuinely altered. And at that point,
the neurochemistry, the chemistry, there's just like this switch that goes on, and the way the chemicals interact with each other, and the whole neurochemistry is different, right?
Exactly. And so now we've tipped more into the clinical frame for addiction. And really at that point in time, it's not unusual people are not amenable to psychotherapy, not just EFT, right?
Any psychotherapy.
Any psychotherapy, right. It's just not going to be useful. People can't integrate it. They can't organize well enough around it. They really have to dry out.
Right. Yeah, it's just, it limits the cognitive functioning so severely, so much, the physical functioning, you know, it just becomes too big of a limitation for psychotherapy.
Exactly. So at that moment, it's contraindicated, but we can really work well and effectively all the way up through dependency. And again, we're always tailoring the model, and that has a lot of different looks, if you will. But therapy, people are amenable to therapy, and I would say amenable to EFT. We just not the full course.
Yeah, not the full course means we're going to be much longer in stage 1 work. We're going to be making some adaptations, like more psychoeducation. Of course, it's how we do it. We're still doing it bottom up, but we're doing that more frequently. We're putting those the context around it much more often, because you have to do those things to create and maintain safety, right? So those are all based on what we're sitting in the room with, but those modifications are really, and who you lean on more in the way of the process, because you to keep the safety, then we have to, there's a balance there, right, between the user and the non-user, and who you can lean on as far as keeping the safety in between session, or even in session to some degree, right?
And then even the relational impact of the addiction, because that varies greatly, right? And that really predicates who we're working with and how we're working with, and how fast or slow we're going, if we're going to put in prescriptive interventions or not, and that kind of thing.
Yeah, so then we're starting to talk about, let's just slow down for a second, because I think there was, maybe we answered the question about the addiction versus the dependency. Because it is the dependency, when people start to feel that, it is both emotional, mental, physiological, because they've been moving to use the process or the substance to regulate them, right?
Exactly. With repetition over time, so it's really affecting the neural pathways.
Very big neural pathway to do that, which limits their felt sense or ability to make other choices, right?
Exactly. Yeah, we could go down a lot of roads from that juncture there, but yes, it does. Just in terms of activating the normal attachment neural networks that would normally move us towards social interaction with our significant other in order to regulate, people start overly relying on a process behavior or substance so much that the need and pull to move toward the social interaction starts to really diminish and deteriorate. And without that, the optimal functioning of the brain starts to deteriorate, and then it's a really slippery slope at a certain point.
Yeah. So that's so cool. I'd love to have you repeat that, right? Because just repeat it. That was so important.
Sure. So I'm not going to claim ownership. This is Jaak Panksepp, and what he talked about was, if we look at ourselves as social animals, social mammals, social creatures, part of the way the brain functions in its most optimal way is through social interaction. It's an open system. The central nervous system is an open system, which I love because that smacks against all the stuff about rugged individualism and fears of or downgrading dependency.
Yes, so that feedback loop, I mean, if people aren't familiar with Jaak and those terms, we're talking about that malleable feedback loop, and how social interaction, that openness to what we're receiving, sending and receiving, changes us as we move along, right?
Yeah,
and we can't just do it on our own. That creates a closed system, and that has a propensity to self-destruction.
Exactly. And so to take some of your language then, by repetitively moving toward behaviors and or substances as a way of regulating affect, that all of a sudden we are a closed system, and the actual networks that are responsible for compelling us or propelling us to reach get degraded and deteriorate over time. And then it becomes much more of a self-perpetuating vicious cycle, if you will. Yeah. Where people's brains and neural networks and the pathways they're in that are naturally organized around reaching and social interaction, start to shut down, deteriorate. I don't know if they actually prune, but I know they are not used as much, so they actually are not as accessible.
Right. And that leads us right into the attachment, right? When we're talking about this movement towards away from social, away from other, and towards self-regulation with something else, something outside of their attachment bonds, and becoming kind of bonded to that really makes it clear how that interferes and escalates the negative cycle between people, because it really becomes a block towards developing secure attachment, which when we're insecure, we're trying to move towards developing.
Yeah, right. Well, the tricky thing is, so I like, that's a good segue. So what I think we bring very beautifully to working with addiction, and I think this is where I think EFT actually adds something to the addiction field itself. I like to equate addiction to the common cold. It's everywhere, and we've been working with it forever, and no one knows how to cure it. And the most utilized resources still have incredibly poor efficacy, period. They just very, very poor. So all that being said, if we start looking at the human being and we look at contextually somebody beginning to use, whether it's behavior or substance, as a consistent way of regulating affect in times of vulnerability, it speaks to their lives, right? In other words, our attachment strategies are based upon expectations, and these are bad expectations. No one's going to be there for me when I need them.
And they're created from an open system where the feedback has been, you're not going to be there for me, or you're going to hurt me. And so I can't reach to you. I actually have to start to look someplace else.
That's right. And the reality, I would say, well, especially with substances, and there certainly are some process addictions, the change is immediate.
Right.
You know, you take a drink, you're altered, it works.
Right. And it's so fast. It's so quick, the change. The relief is so immediate that it becomes so compelling.
Exactly. And it's effective at what it does. It just becomes, again, another vicious cycle. And so that pulls people away from their partners and often creates all sorts of havoc in terms of deception and lack of responsibility and disappointments and all sorts of things that can spiral in so many different directions.
Yeah.
So that's where we see it starting to organize a system.
That's right. And that's something that we do very differently than other psychotherapies, using both attachment and emotion together in the systemic frame. And I think about stage one, there's a question here from Maria, maybe this addresses this a little bit, because in stage one, one of the things that we're doing is we start to dip down into their emotional system, but we're holding the context. And holding the context keeps kind of the mental frame, you know, what is happening, what's happening, why it's happening, where it's happening, you know, it keeps this container around as we put it in the cycle, right? Exactly. So we dip down and then we see how much tolerance is there for that accessing of emotion by what happens in the system. Does it get more reactive, or does it calm it? And so Maria asked this question about, you know, do we need to be careful about not flooding them when we're accessing emotion to try to get them to open their systems, right? And EFT does that balance of looking of co-regulation, both intrapsychically and interpersonally within the system.
That's right. And, you know, I guess Maria's question is really about pacing, right?
Yeah.
And so that's going to go, you know, be so individualized. And it really depends. I know we've all had experiences where we have moved too fast. And quite frankly, what usually happens there is people shut down. It's not that they flood so much and they snap into a fetal position. That can happen, and it does occasionally. But if you put that on the bell curve, that's on the farther reach. But most of the time, people shut down. At the same time, there are people who I would make an assumption, and wrongly, that they would not be able to engage well, and they engage beautifully. So doing what we do and have that lovely attunement with our clients and take their lead on that and continuing to apply that gentle, persistent pressure, all things being equal, what often can happen is we start to humanize the addict's experience in a way that is often so stigmatized by the addiction. And it's very powerful for them to be able to start speaking in a way where they don't feel like the identified patient. And this is from, again, bottom-up process, engaging them emotionally, getting into their truth, seeing their humanity, seeing how it feels that bad they'll use, reaching to their partner, the partner's let in. Now, sometimes a partner is so hurt that doesn't go well, and that's a whole other thing, right? And we have to work well with a partner who is so angry at that point. But I think the way we work really, to your point, it creates a container and a way of organizing and understanding a process that is so easy to see in a very disparaging way, right?
Yeah.
So I
Yeah,
think,
with bringing that humanistic view into
yeah,
it. I loved how you said that, you know, that we end up humanizing the addiction experience or the addict's experience
too.
for them and for their partner, right?
Right, right.
And so this process starts to unfold in a way that they can start to claim and honor and respect the pain and the movement away from each other as, you know, that indication of the pain that that they actually are missing the secure attachment.
Right.
So that's really, really, and you mentioned pacing, and that is, you know, being able to go slow. And it is so gray. There's so many complexities to it
Right.
that we have really, it kind of requires us to go slow, At least it requires me to go slow, because
Yeah.
there's like these, otherwise I can miss all of these components. You know, because we are also made to simplify things, chunk things. You know, our brains are kind of made to burn less energy than more, you know, it's kind of simplified. And if we're going too fast, we're going to over simplify, not be able to hold those complexities.
I agree. But, you know, the thing I find more, I don't know, I'd be curious to hear about your practice, but I find that it's actually over-regulation that I run into more. And for somebody that
Absolutely.
has turned off their attachment and addiction and emotional system for so many years, helping people find their way to emotion is really complicated. And it can take a long time. It's very slow oftentimes. So I
absolutely. It's so that the system is so defended about being vulnerable.
Yes.
And there's been this quick move to a substance or, you know, away from the social risk, a quick move to a process or, you know, a behavior to move away from that vulnerability, that is so, like you said, the neuro highway there is so well developed that it's so automatic to kind of move into that protection.
Oh, exactly. And oftentimes people have been doing it for years upon years upon years. So we are moving into an area that there's very little template for. And that can take a long time to develop, you know. And as we were saying before, there can be a lot of shame behind the scenes, which understand why people wouldn't want to feel. So yeah, it's attunement. And sometimes I just find myself putting that general persistent pressure to try to move people toward their emotional experience, at least have them articulate their appraisals of what's going on and begin to talk about that and understand that, reach to their partner with that. And it might be a while before I see people really expressing much more dramatic emotion, if you will, if ever.
Yeah.
Sometimes that happens, sometimes it doesn't.
You know, one of the things that you do so well, like I don't know if people have had a chance to see your work, but on that in session where I have trainers come and show a session, and you've been part of a couple of seasons of that training program that I do. So I'm just letting people know they have an opportunity to see your work if they haven't.
Thanks.
One of the things you do so well, as we talk, what you're talking about reminded me of, is the way that you validate. Like I'd just say you're the validation king. You know, like any little move towards or away. You know, any little move away from their internal experience, away from the other, you're able to recognize and hold and validate that. And that's, along with the pacing and the attunement, really helps people to start to dip into a bit of their internal world and deal with some of the shame, that because the more human that we are, with the more they feel we see them as human.
Right.
That helps bust some of the trauma and the shame in a way that they can begin to experience a little bit.
Exactly. Just walking right alongside them, and again, in a human way, to make sense of their experience. And it all makes sense when we slow it down enough and try to get into their shoes. And all of a sudden, we start really understanding more what they're really medicating. There is so much shame, or there's been so much trauma, and who wouldn't if you had the chance, if there weren't loving others around, right?
That's such a great way to say it. Like, what are they really medicating? Because even if we ask the assessment questions and we get what they're doing, you know, trying to get a sense of why they're doing it. Like, what is the pain? What's there is more important than the what, right?
Yeah, exactly. Yeah, we start to see addiction, just like the other attachment strategies, is very functional, right? Dangerous and functional. There's a function to it, right?
Yeah.
And you start to
and
zoom out.
At some point it begins to work against them. They wouldn't come into our offices if they didn't have some sense of it's working against them as well.
Yes.
Right.
Yeah, and it works against the relationship.
Yeah, it works against the relationship.
Yeah, exactly.
So that understanding that neurobiological thing that happens, and both with the attachment and with the process or substance use, is kind of that place that we have to keep in mind. And I think one of the things that is an adjustment when we're starting to work with couples or addiction in EFT is that holding of the addictive process, of keeping it kind of up and running as part, like we would, you know, attachment or so. When you feel this trigger, then what, you know, if we think about the process of emotion, when you feel this trigger, then the danger is and your fear is, and so you do this, that we have to keep in mind that move away from risking with the other and moving towards the process or the substance. And, you know, sometimes with the shame and everything in the room, like holding that up as a mirroring, as a process reflection, can be quite tricky for us to do. And I think that's one of the most essential elements, is to kind of keep it up in the foreground.
Yeah, no, I would agree. And to your point, the shame can come up, which so often in my experience ends up really validating the need to use, because people feel so bad about themselves in that moment. The way they cope ends up digging the hole so much deeper, because then they shut their partner out, or terrify their partner, or let them down, and their partner gets upset. Then they feel terrible about disappointing their partner. Here comes the shame, and then they use, and it's like a cycle within a cycle, right?
And then it makes it kind of terrifying for us to lean into that and to reflect that process, because we can trigger the shame of that within the system right there, because there is so much shame around all of that.
And the other side, though, it's worth mentioning too, is if we can bring it online and the person can tolerate it and they can reach to their partner, then we have a profoundly new moment, right, for both of them. And that's usually a real aha moment for couples, which I have to just kind of sing EFT's praises in the way that we use all of that, because all of a sudden a person is reaching, the person's reaching for their partner, and we're making that explicit, rather than reaching for something, substance or process to regulate or kind of buffer shame.
And they're even letting us co-regulate with them because of that motivation towards their partner, right? So the other thing I think about the shame is, even though it's really scary to keep that, you know, reflecting what's happening there in the process, keep the addiction, you know, the movement towards it up and running, that view of self that comes forward, you know, that shame that comes forward, and the negative view of self and view of other, that our being with them in that is so co-regulating for them.
Yes.
If we can, as we can learn to tolerate that they feel horrible about themselves, you know, and that it's an awful feeling, and, you know, that they feel like scum of the world or something, that we can even as we can learn to articulate that and be with them, that starts to calm their system. It's very regulating.
Absolutely. We really hold it with them. And in that moment, they're not alone with it, which is the Achilles heel of shame, right? The aloneness with it. It's too much to bear alone.
Yeah, to not be so isolated.
Right, and the coping strategy is to isolate.
So, so Maria and Janet, we appreciate some of you giving us some input and feedback in the chat box. If you have other questions, if you have things that you want to say or share with us, we appreciate you being here and commenting in real time with us. So just want to notice that and continue to encourage that. So Janet asked this question: is there more time needed in stage 1 to be sure that de-escalation has taken place?
I probably wouldn't phrase it that way. I would say stage 1 seems to almost conclusively take longer. We are dealing oftentimes with couples who there has been betrayal, attachment injury, all sorts of stuff has happened from the processes of addiction. And then we have oftentimes a partner who is very upset, the non-using partner, with the using partner, and a using partner who's often deactivated their attachment system and their emotional system. So we have our hands full. And in order to begin to get underneath the action tendency of addiction and move into kind of no man's land or no woman's land, takes a long time. And often having to deal with the sometimes seething anger of the fallout relationally from what's happened with the addiction, it takes a long time to kind of settle things down and create a more peaceful environment where we can do some of the work. So I think stage 1 takes a long time. And then so often, much more often than not, trauma is part of the picture.
Yeah.
And so we have our hands full. It's extremely complex psychotherapy, I think. You know, I love that we work systemically and we have a clear way of working systemically, because it organizes our work and it creates safety in the work. Just the way we organize emotional experience from a start point of people's distress to a predictable narrative that we help them distill and articulate, to moving them into emotional experience, which is often a huge aha for both people, and then seeing how that overwhelming experience would naturally lend itself to addiction or using or whatever it might be.
Right.
Really helps hold people well. So we do a lot of that, a lot of repetition, and it moves very slowly. So I hope that answers the question.
Yeah, yes. And as Maria says, these are not the cases that we're going to be doing in 20 sessions.
Right, exactly. Yeah, no, these are not those cases. Right, exactly.
Right. And stage 1 really is, no matter how quick the case goes or how long the case goes, stage 1's going to be kind of the longest anyway, right?
Right, right.
So it will be elongated when you add use, abuse, addiction, you add shame, you add trauma. All of those things are going to, anything that adds kind of to the complexity is going to, and that has impacted people's resiliency, is going to end up taking longer. Right?
Exactly. So it typically does take quite a while. Then you'll typically deal with some relapses and have to make sense of that. And it takes a while. Yeah.
Yeah. And the complexity actually is, I mean, some of us really like it because of that, you know, that bit of complexity. And also I think that couples are also some of the processes that lead into use or abuse, or like some of the ways people have strengths, are like couples don't not know that often, right? It's not like they don't know that their partner's complex or has pain or has, you know, some darkness inside of them. Many of them will say, I like that about, I like that about my partner. I just don't like that it ends up doing this, right? So it's not, I mean, I've heard lots of people who would say, you read a book or something, they'll say, oh, just don't see somebody that does this or that. But a lot of people are really drawn to a complexity of experience and a depth of experience that those who have suffered more than most, or who haven't had the most secure development, and the complexities around that development are quite attractive.
Yeah.
Yeah.
That's true. Yeah.
So, and we may like that in our work as well, right? Not that we don't like to help them come out of the pain, but so Jennifer asked this. She says, you talked about the importance of individual, group, and couples work for the addict and the partner. When do you decide to start with couples therapy so not to cause further trauma for the partner? So it's kind of an assessment of would we start to see this case, under what kind of conditions would we not?
I feel like if I can have safety in the room, I will certainly move forward with EFT. If I feel that the addictive process is something that we can stabilize enough for them to do couples therapy, I'll move forward with it. Sometimes I keep mentioning prescriptive interventions. Like one of the things I like to do, which actually came from a different mindset, but was to say to people, I understand you're using, but what I'd like you to make a commitment to is the day before therapy, the day of therapy, and the day after therapy not to use, because you're not going to be able to integrate the work we do. Right. And in a very practical way, that's almost half a week they're not using. So I use that diagnostically, because if people can do it, that's great. And that gives me a lot of information about that. That's very prognostically great. If people can't do it, then maybe they're needing additional levels of support, and or couples therapy may not be time. It depends what's happening in the therapy. So I will start exploring things in that way. That question's a tricky question because it depends what people are presenting with. And all relationships are a bit unique in that somebody who uses a little bit in a way that we might put into the use to abuse category might be blowing their partner away. Maybe in their history, they grew up in an alcoholic home or something like that. And so their partner's using is not addictive in any way, shape, or form. And this person might not need additional supports. But there's something going on that every time that person uses, it throws the relationship into a tailspin, and we have to evaluate that, right? So it's a tricky question. It's a contextual question without the context of the real case. But I try to play around with different things. If I think people are drinking or using or having certain kinds of process addictions, I will try to offer ways of containing it somewhat and seeing what the person can do with that. And
you kind of use it. I mean, you call it a prescriptive intervention, but it's a bit of an assessment, right? It's a bit of an assessment.
It's diagnostic.
That's diagnostic. It helps you to see where they are. Can you create safety? What happens in the system when? And then also it's really practical. Like if people are using substances, not as much with process addictions perhaps, but certainly with substances, can't do a lot of work when they come in high or loaded or whatever. You just can't do it. So like you kind of have to set that up as a contingency for beginning treatment.
Or I even believe treatment. If they go home and they use after a session, they haven't come in high or they haven't come in altered, but it will get in the way of them integrating the work that we're doing, right?
Yeah,
so
absolutely.
I just think it's a really nice way of safeguarding the work that we do and preparing them for that. And again, it's diagnostic. It's a very interesting intervention.
Yeah, it's very cool. I do that. I just hadn't put those words around it like that. But I mean, because you just know, like you can't get any work done if they're coming in and using before or after. So I thought of it as practical, but it's really interesting to think about and look at the implications and what's the blocks to doing that, and if they can or can't, what else do you do, and can you do it? So exactly. One more question. It looks like we got about 5 minutes left, and let's see what we can do here. Maria says, how do you deal with individual therapists working with your addicted partner and seeing your work as encouraging codependency? How do you work with that in the room with your couple where the addicted
Yeah.
person's learning from two different perspectives. Oh, it's just such a rut, isn't it?
Yep, it's a rut. So, again, I would generalize that question too. It's not unusual that as EFT therapists, one or both people are working with other therapists individually, and if that other therapist doesn't have an attachment frame, right? Oftentimes, the clients get caught kind of in the crosshairs. And I think it's even more accentuated with addiction, and the way codependency is often framed. I mean, codependency is just another strategy. It's another strategy, and it makes sense when you get behind it. But in our culture and the way we use it, it's a catch-all for something that's a bit derogatory.
Yeah, it's another, just a shame label, isn't it?
It's a shame label. It's a terrible shame label. Yeah, exactly. And those are hard conversations. I always recommend talking directly with the individual therapist, getting releases signed, and just let's put our heads together here, because we don't want to work at cross purposes with our clients, and I think we might be. And here's what I'm attempting to do. Here's my framework. One of the things I have found, and this is another super cool thing about EFT, in my opinion, we have operationalized our therapy very, very well. And I have found that when I speak with other therapists, I can speak very eloquently about what I'm trying to do and why, what's happening. And it's often very illuminating for people. And I think some of that's inherent in the model. I think the model lends itself to that. So, to have a conversation about the concerns and the way this might be putting the couple or the individual in the couple in a very complicated position, I think is a very worthwhile set of conversations to have over time, and trying to find out what that therapist is trying to accomplish with their individual work, and can these goals be compatible. Now, sometimes that works great, and sometimes the other therapist is not willing to bend. And that's just a tricky spot for all of us as psychotherapists. That really happens when we do couples therapy. So I don't think it's specific to addiction, but the codependency piece.
No, that's right. Yeah, that's right. Yeah, trying to bridge those gaps as we can. And sometimes we can't bridge them, and it becomes intolerable for our clients to work with another professional who we are at cross purposes with. And those can be really tough situations. So, but certainly it behooves us to try to bridge those kinds of gaps, right? Get those releases, talk with the other therapists, let them, use your best. How to win friends and influence people, understand, right? Where are they coming from? What are their goals? What are they trying to do? And then trying to find those common grounds with them, and educating them about what we're doing and why. And I think that kind of the truth about attachment and who we are as human beings and our humanistic perspective often can help bridge some of that, not always. Yeah.
No.
Okay, so let's see. We want to let people know that there are trainings also. You're involved in doing a lot of trainings that people can find. So why don't you just tell them a little bit about, Michael, where they can find you? And
so I am doing, at the very end of March, I will be with the Sacramento Center in California, and I guess you can find registration on their website. I don't know exactly what it's called. Sacramento Center. I don't know.
It's called SACDEFT.com, I think.
SACDEFT.com. So that is the very end of March. And then about a week later, I'll be up in Vancouver, and I will be doing the masterclass on addiction with the Vancouver Center for EFT. In May, Dr. Sylvina Irwin and I are doing a 2-day masterclass on trauma and EFT in New Orleans. And in October of this year, I'll be down in Boca Raton doing the 2-day masterclass on addiction.
Yep.
And that'll take us through 2019.
Yeah. So you do these trainings, Michael, you've got quite a few on your schedule. Jim Thomas also, and I also. So we meet less often, but certainly do them and have done them lots of places. But they will be found either at the those individual sites, or those
My
master
website.
classes are listed at ICEFT that you can watch for those. Yeah.
And I think they may be on my website as well. It's a new site, so I'm trying to remember, but it's michaelbarnettlpc.com.
Okay, great. So Michael, thank you so much for sharing your encouragement and your wisdom, and some of these places that we just get a little bit afraid and stuck and need some help, and just the container around what is it that we can do and where we're not limited, really. And we're a lot less limited than we used to think that we were.
Yeah.
So we're finding so much more success with along that spectrum, where there is maybe active use, maybe active abuse and dependency, and we're helping people move out of that through the stage 1 work and into more secure attachment. So
Yes.
thank you very much for your pioneering.
You're welcome. This was so nice. Thank you for having me. I enjoyed it so much.
Thanks. And thanks everyone for being here. Appreciate you. And being members of ICEF. So we'll try to keep you getting the education you need to work with attachment and EFT. Thank you.